I'm Andrew Murray. I'm an assistant professor at the University of Pittsburgh in the Department of Anesthesiology. And the topic for today's discussion is pharmacology of anesthetics, dealing specifically with opioid and IV anesthetics. The objectives will be to look at these individual intravenous agents: opioids, barbiturates, propofol, etomidate, benzodiazepines, ketamine, and alpha agonists. The opioids, the mechanism of action, there are specific receptors on presynaptic and postsynaptic locations of the CNS and the periphery. They tend to be most effective in situations involving peripheral inflammatory nociception, and they mimic the effect of the native ligands, which so the endorphins, the enkephalins, and the dynorphins. You can see the receptors over here in this table. You've got mu1, mu2, kappa, and delta, and the effects are as listed. The analgesia comes from all four of those receptor types, and the agonists, the ones that we use most frequently, are the synthetic opioids and morphine, so mu1 and mu2 receptor agonists. And you can see listed on the bottom of the table, naltrexone and naloxone are antagonists for all four of those receptor types. Pharmacokinetics and pharmacodynamics, as you can see in this table as well, the PK and the clearance for all these medications. You'll notice that fentanyl and morphine have the highest clearance, except for remifentanil, which we will talk about later as to how this is beneficial in the way that we use it. The neuraxial pharmacodynamics, these agents target the substantia gelatinosa mu receptors. The effect is both on local receptor binding as well as systemic absorption. The epidural dose is typically about 5 to 10 times the subarachnoid dose, and you may see a possible decrease in the mean alveolar concentration of your inhaled agents. With regards to metabolism and excretion of opioids, the liver is the primary biotransformation site. It has a very high functional reserve. The remifentanil metabolism is not affected by liver disease at all. Patients with hepatic encephalopathy are more prone to sedative side effects than those with normal liver function. Renal failure is very important in regards to specifically morphine and meperidine. It's not as important for fentanyl and other congeners, and there's no importance in remifentanil. The reason why it's important is because morphine is metabolized to morphine 3 glucuronide, which is inactive, but also morphine 6 glucuronide, which is active. And in the face of renal failure, you end up with resultant accumulation, and so you also have active metabolites that are accumulating as well. With regards to the circulatory effect of opioids, bradycardia is induced via increased vagal tone. Vasodilation is induced via depression of the brainstem vasomotor center, and this decreases preload and afterload and is exaggerated in patients with high sympathetic tone. So, for example, patients who have heart failure and are already relying on very high sympathetic tone may experience a significant blood pressure drop when presented with opioids. There is no real effect of opioids on contractility. The respiratory effects of opioids, primarily ventilatory depression. Opioids do alter the response to arterial CO2, and you end up with a flattened and right-shifted response curve, and this results in a decreased respiratory rate as well as a decreased tidal volume. And then patients can be start this one again. Other organ system effects of opioids, patients may develop muscle rigidity. This usually occurs with high and rapid dosing. Not entirely clear what the mechanism of action is, but it does also correspond to the loss of responsiveness from the patient. Pupillary constriction can occur. This is a somewhat useful diagnostic sign for ongoing opioid effect. And then patients can also develop urinary retention in the post-op period. Side effects and toxicity of opioids. The one that is most commonly mentioned is nausea and vomiting. This occurs via the chemoreceptor trigger zone in the area postrema of the brain, and it's usually worsened by movement. Patients can also develop depressed cellular immunity in the case of morphine, and then patients can also develop ileus of the bowel and of the biliary tract, which is certainly a concern in patients who are having procedures where they need of the gut, where they need to regain their gut function soon post-operatively. Indications and contraindications for opioids. They can be used as sedative agents. They can blunt the sympathetic response to intubation. They can be co-administered in general anesthesia for analgesia. They can be used as a primary analgesic in the post-operative phase. And they can also be used for cough suppression in the intubated patient. Moving on to barbiturates, we'll talk about two barbiturates. The first one is thiobarbiturate, which is, the example is thiopental, which is typically a 2.5% concentration. And then the oxybarbiturate is methotrexate, which is a 1% concentration. Pharmacokinetics, redistribution typically terminates their effect. Elimination depends on the metabolism in the liver. They are highly lipid soluble and 80% protein bound, and distribution depends on protein binding and ionization, lipid solubility, and drug concentration. Pharmacokinetics. In the brain, the peak brain levels occur within 30 seconds. Redistribution is usually within about 5 minutes, and this results in a awakening after about 5 to 10 minutes after administration. The other location that it will distribute to is the muscle, which is really the primary redistribution site. The equilibrium is reached within about 15 minutes. And then fat peak levels are at about 2.5 hours after the initial dose, and will serve as a depot for redistribution later on. As mentioned before, the onset of barbiturates are related to lipid solubility and protein binding. Thiobarbiturates are more protein bound than oxybarbiturates, and this goes somewhat to explaining why oxybarbiturates will have a quicker onset time. Ionization is important. The pKa of sodium thiopental is 7.6, so therefore about 50% is non-ionized at a physiologic pH of 7.4. Methotrexate, on the other hand, is 75% non-ionized, and then so therefore explaining its quicker onset as well. Acidosis also favors central nervous system effect. Drug concentration, as you might imagine, a higher dose and rapid administration will result in a much quicker onset and effect. Metabolism of barbiturates occur mainly in the liver. With sodium thiopental, it is achieved by oxidation, N-dealkylation, desulfuration, and barbiturate ring destruction. And this results in the production of hydroxythiopental as well as pentobarbital. And the clearance is about 0.15, which designates this as a capacity-limited agent, which really means it should only be used in bolus form as opposed to used as an infusion. Methotrexate, on the other hand, mainly oxidation to inactive hydroxy derivatives, and the clearance here is 0.5, and it is therefore a flow-limited agent. The 0.15 and the 0.5 refers to the fraction of drug that gets cleared by the liver on a single pass. So imagine that 15% of sodium thiopental is cleared, whereas methotrexate is 50%. As far as elimination of barbiturates, the T half-life is long in the obese as well as the pregnant patient. It's typically short in the elderly and the pediatric patient. The slower clearance of barbiturates has somewhat contributed to it being replaced by propofol, which is cleared very rapidly. Central nervous system effects of the barbiturates. It does provide some neuroprotection. Theories for this effect is that it may decrease CMRO2 and also cerebral blood flow with a decrease in ICP. Also, there may be free radical scavenging. No real evidence, however, in patients with cardiac arrest without intracranial hypertension. Not all barbiturates are equal, so the sodium thiopental has been the mainstay for protecting the nervous system. Hypothermia, however, still remains better than the barbiturates for doing that. Typical EEG effects that you might see is the development of fast frontal B wave or beta waves, frontal alpha spindles, as well as diffuse deltas all the way down to silence. Respiratory effects of the barbiturates. There is a dose-dependent depression of the medullary and pontine centers. Onset is typically at 1 to 1.5 minutes, with offset being about 15 minutes, and sodium thiopentol. Apnea might occur in about 20% of patients induced with sodium thiopentol. And the patient will then resume breathing with slow, shallow breaths. Airway reflexes are typically retained until very large doses are reached. Cardiovascular effects are greater from sodium thiopentol as opposed to methotrexate. Typically, you'll see a decrease in the cardiac output and the blood pressure, roughly about 10 to 20 millimeters of mercury. And this is all premised on decreased contractility, preload, and sympathetic outflow. There is often a compensatory heart rate increase of about 10 to 36% of the basal heart rate. But throughout all of this, the O2 supply and demand ratio of for myocardial perfusion remains stable. Other side effects: it does increase renal blood flow and GFR. There is a modest decrease in hepatic blood flow. If it is used as a prolonged infusion, for example, in patients who might be receiving a sodium thiopentol infusion for brain protection, you will see enzyme induction and therefore increased metabolism of agents that are metabolized in the liver. It does stimulate D-allosynthetase, which may cause porphyria. And then also, if this agent is injected into an artery, you can certainly see arterial injury. And even in venous injection, patients may develop phlebitis. For the management of the arterial injury, it usually requires dilution, heparinization, and maybe even brachial plexus block if it's an upper limb vessel that was injected into. Indications are seizure control, brain protection via burst suppression, and the decrease of the CMRO2, hypnotic for facilitating anesthetic induction, and it is not for continuous infusion use in anesthesia due to the prolonged context-sensitive half-life. Contraindications: hypovolemia, cardiomyopathy, coronary artery disease, and cardiac tamponade. All of these are relative, but they are tied to the circulatory effects of the barbiturates. One of the absolute contraindications would be porphyria, because, as we mentioned before, it stimulates D-allosynthetase and will produce a porphyric crisis. Next agent we're going to speak about is propofol. This is an alkyl phenol, usually prepared in a 1% solution. The solvent is typically 10% soybean oil, 2.25% glycerol, and 1.2% lecithin, which is a purified egg phosphatide. Preservative is typically metabisulfate and benzyl alcohol. And it is also preserved with disodium editate in some circumstances. You do need to use this within 6 hours of opening, otherwise it may become contaminated and should not be used for patients after that. Pharmacokinetics of propofol are best described via a 3-compartment model. The T-half alpha is about 1 to 8 minutes. T-half beta is about 30 to 70 minutes, with an elimination T-half of 4 to 23.5 hours. Volume of distribution is ranged between 2 and 10 liters per kilo. It's typically a flow-limited metabolism, and it is therefore useful as an infusion for sedation. Context-sensitive half-life is less than 40 minutes with an 8-hour infusion. Metabolism is typically rapid to glucuronides. Elimination is via the kidneys and the lungs, and it does inhibit P450. Liver disease patients may have an increased volume of distribution and a T half-life, but often this is not clinically relevant until very little liver reserve is remaining. The CNS pharmacodynamics, its effect is on the beta subunit of the GABA receptor as well as the alpha-2 adrenoreceptor. It is hypnotic but with no analgesic effect. So you have to take that into account when doing an induction. Acetylcholine release is induced in the hippocampus and the prefrontal cortex. And there's also a decrease in or depression of the NMDA subtype of the glutamate receptor. The ED95 is about 2 to 2.5 milligrams per kilo. ED50 closer to 1 to 1.5 milligrams per kilo. And the EEG effects are very similar to sodium thiopental. Neuroprotection, however, is not like sodium thiopental. It's fairly controversial as a neuroprotective agent. You do get a decrease in the CMR02 of about 36%, as well as the cerebral blood flow and the ICP. Autoregulation is retained for both blood pressure and carbon dioxide. Cardiovascular effects typically are more profound than sodium thiopental. You get a decrease in blood pressure, and this is premised on the preload and afterload being reduced, and this is related to the amount of central nervous system outflow causing more vasodilation. Baroreceptors are typically suppressed, and patients may develop, what has been described at least, that patients may develop bradycardia and possibly even asystole in some of the young, healthy adults. Respiratory effects are like sodium thiopental, dose-dependent depression, a slightly higher incidence of induction, with 25 to 35% of patients becoming apnea with induction. Typically, the depression is related to a decreased tidal volume as well as an increased respiratory rate with infusion. And the carbon dioxide response slope is also decreased. Patients with COPD may benefit from propofol, secondary to bronchodilation that may occur, and hypoxic pulmonary vasoconstriction is also decreased. So this must be taken into account in patients who are having single lung ventilation for their anesthetic care. The other point about this is that with the apnea being slightly higher percentage with induction for general anesthetic, it also translates into sedation cases where you walk a much finer line between apnea and adequate respiration for the patient who's on an infusion for a sedation, and so ventilation should be very closely monitored. Other effects, you may see a decrease in emesis, and subanesthetic doses have even been used to treat these. There's a decrease in pruritus with intrathecal opioids, no real change in adrenocortical hormone. Patients can develop propofol syndrome. It is safe in MH. It's contraindicated for pediatric ICU sedation, although this seems to be a relative contraindication. The phagocytosis and bacterial killing is unchanged, but there is a decrease in chemotaxis. And then the other problem we mentioned already is the risk of contamination of the vial if left, if not used within 6 hours. Indications typically are for induction and maintenance of general anesthesia, as well as for sedation for the ICU and also for procedures, and then it might be used for antiemesis as well. Contraindications, we mentioned propofol infusion syndrome already. Patients can develop metabolic acidosis, hyperkalemia, lipemia, rhabdomyolysis, hepatomegaly, and then cardiac and renal failure. And they're contraindicated really for the unmonitored patient due to the points we mentioned already, specifically respiratory depression as well as hypotension and the other cardiovascular effects. Moving on to etomidate, this is a carboxylated imidazole. It's specifically the active D-isomer that is active, and the change in physiologic pH increases its lipophilicity. Patients may experience pain on injection. There is no precipitation when mixed with rocuronium, for example, as might occur with sodium thiopental. Etomidate is metabolized via ester hydrolysis and then rapidly cleared via the kidneys. Induction dose is 0.2 to 0.6 milligrams per kilo with a maintenance of about 10 micrograms per kilo per minute if being used with nitrous oxide. T half alpha is 2.7 minutes, T half beta is 29 minutes. There's a higher extraction ratio than sodium thiopentol, up to 5 times higher. 75% of the agent is protein bound, and there is no really real effect from cirrhosis. Patients will have a greater effect than in the elderly. Etomidate pharmacodynamics with regards to the central nervous system is like propofol, a GABA-like effect. The potent cerebral vasoconstriction that occurs results in a decrease in intracerebral pressure, decreased CMRO2, and decreased cerebral blood flow. Burst suppression is also achieved as well, which is associated with the decrease in the ICP. The CNS protection is still somewhat controversial with etomidate, though. EEGs are typically like sodium thiopentol, but without the beta waves. It may actually activate patients who have pre-existing seizure foci. Myoclonus usually also shows up on the EEG as seizure activity as well. SSEP effect of this is unlike the other agents. You actually get an increase in amplitude and latency, whereas the others will cause a decrease in amplitude and an increase in latency. Respiratory effects. There's no histamine release with etomidate as there is with sodium thiopentol. The CO2 response is similar to methotrexate, and the depression is exaggerated with high doses of opioids. Cardiovascular effects and minimal blood pressure changes with minimal myocardial depression, which is why etomidate has such great use in the cardiac arena because of its stability for the patient's hemodynamics. Endocrine effects, there may be 11-beta hydroxylase suppression of cortisol production, which may last up to 4 to 8 hours even after a single induction dose. It's not entirely clear what the clinical relevance of that particular fact is, though. Other effects are that there is an increase in nausea and vomiting with etomidate as compared to the other induction agents. You may see an increase in mortality with ICU infusion utilization. There's no sympatholysis, so you have to make sure that you provide some measure of sympatholysis when using etomidate for induction. Adrenocortical suppression is really not clinically relevant at this point. Indications mainly are for induction of general anesthesia. Benzodiazepines are the next agent. Diazepam, which is typically diluted in a propylene glycol. Lorazepam, which is in polyethylene glycol, and midazolam, which is water-soluble. The benzodiazepines are metabolized in the liver to hydroxides and glucuronides. For example, diazepam is metabolized to 3-hydroxydiazepam and then excreted in the kidneys. Midazolam is hydroxylated and then conjugated into inactive compounds, and lorazepam is broken down to inactive glucuronides. The context-sensitive half-life of midazolam is very short, and therefore it allows it to be used as an infusion, although it is still not flat, as you might see with remifentanil. As you can see here in this table, the midazolam is the shortest half-life with a half-life of 1 to 4 hours, and it has no active metabolites, whereas diazepam has a rapid onset of action, which is beneficial, but the half-life is 20 to 50 hours, and it does produce active metabolites, which means you will have a significant amount of accumulation, and so it is not really usable as an infusion agent. Continuing with pharmacokinetics, the clearance of midazolam you can see is 6 to 11 mils per kilo per minute, which is the highest of the three, and it's typically cleared by the liver and the kidneys. As a result, you might imagine that if there is renal and hepatic dysfunction, then this is also going to affect the clearance of midazolam. You can see also further in that box some of the other items that might affect metabolism of lorazepam and diazepam. The pharmacodynamics of the benzodiazepines, this does bind to the GABA-A receptor complex. It does have a dose-dependent effect. Potency is as follows: lorazepam greater than midazolam, which is greater than diazepam. and then tolerance is achieved via downregulation of the receptors. Central nervous system effects, you get a decrease in cerebral blood flow and CMRO2, about 34% decrease. There's no EEG burst suppression. You get a beta rhythm at about 15 and 22 hertz. There's no neuroprotection that's been proven in humans. And you get a decrease in cerebral perfusion pressure with severe head injury with no decrease in the ICP. And this would certainly explain why it might not be as protective to the brain in injury. It is an anticonvulsant where it increases the threshold for seizures. It can be monitored for depth with a bispectral index monitor, and there is also some evidence that it may increase the risk of postoperative cognitive dysfunction, certainly in the elderly patients, and should possibly be considered to be avoided in older patients to minimize the amount of confusion or delirium postoperatively. Cardiovascular effects. There's a modest decrease in the blood pressure, specifically the SVR, but does reach a ceiling. It is worse when patients are also concomitantly hypovolemic or already have received opioids. It is useful in severe cardiovascular disease despite this. There is a decrease in the LV-EDP and an increase in cardiac output with the use of benzodiazepines in patients with cardiovascular disease. Respiratory effects are dose-dependent, with about 20% of patients becoming apneic. It usually presents with a decrease in tidal volume and minute ventilation. It does have a synergistic effect with opioids, and there are also decreased airway reflexes and swallowing. The CO2 response is flatter but not shifted, and then age and disease and depressants might affect how the patients respond to benzodiazepines from a respiratory perspective. Indications are really amnesia, anxiolysis, sedation can be used as an anticonvulsant, and also can be used as a co-induction agent, as it does have some hypnotic effect as well. One short mention on flumazenil. It's a specific reversal agent for the benzodiazepines. It is a high affinity ligand for the benzodiazepine itself with no intrinsic activity. It does have moderate lipid solubility, rapid metabolism with a T half-life of only 1 hour, and a high extraction ratio, so it is important to continue to monitor these patients for resedation should they have received a long-acting benzodiazepine before and the effect of the flumazenil wears off. It's also a competitive antagonist. This CNS and respiratory depression is reversed at a low dose. No real adverse effects have been noted, and there's no change in the CMRO2 or the cerebral blood flow. Moving on to ketamine. This is a phencyclidine derivative. It is water-soluble, typically presented in a 1, 5, and 10% solution. And is an NMDA receptor antagonist, and it is usually a racemic mixture of which the S+ isomer is the more potent. Pharmacokinetics, it is metabolized via the P450 system and to norketamine. Norketamine is then hydroxylated to hydroxy norketamine. Short T-half alpha and T-half beta in a large volume distribution coupled with a high clearance results in a metabolism that is flow limited, and as such can be used for infusions. Elimination half-life is typically about 2 to 3 hours. Central nervous system effects. It can cause psychomimesis, which can be decreased with benzodiazepines. It can also increase ICP, CMRO2, and cerebral blood flow. Despite this, however, it has been shown somewhat to be neuroprotective before ischemia has occurred, but not necessarily during it. And the question is whether this is via an anti-apoptotic effect. Myoclonic activation can also cause can be seen on EEG, and it may cause activation of pre-existing epileptic foci in patients who've had epilepsy in the past. Respiratory effects of ketamine are bronchodilation. The protective reflexes of the airway are intact. They may cause increased salivation. So as a result, laryngospasm is something that needs to be carefully watched for, as this can occur in a light plane of anesthesia, combined with the protective reflexes as well as the increased salivation. This may result in the patient developing laryngospasm. Cardiovascular effects, the sympathetic stimulation that occurs can be suppressed with benzodiazepines. There is an increase in heart rate and blood pressure, which can compromise your oxygen supply and demand. It is also has the least intrinsic myocardial depression, so is a valuable agent to use in patients who are very tenuous. For example, the patient who comes to the operating room with cardiac tamponade, and you want to keep them stable for an induction. However, if these patients are maxed out on their sympathetic drive, the myocardial depression, albeit small, may be enough to make these patients unstable. Indications for ketamine usage is anesthetic induction, sedation, and also analgesia. It is a profound analgesic which can be used for frequent painful treatments. For example, escharotomies in patients who've had severe burn injuries to remove the burnt tissue repeatedly. Dexmedetomidine is an alpha-2 agonist. It's a selective alpha-2 agonist. It's an imidazole derivative, and it was noted after patients with chronic clonidine use were seen to have decreased anesthetic requirements. It is a water-soluble agent. Pharmacokinetics, the drug is broken down in the liver via conjugation and N-methylation and hydroxylation. Contact-sensitive half-life is about 4 minutes after a 10-minute infusion and about 250 minutes after an 8-hour infusion. Elimination half-life is about 2 to 3 hours. Dosing is typically 1 microgram per kilogram with an infusion of 0.2 to 0.7 micrograms per kilo per minute. It can be used as a good sedative medication due to its short contact-sensitive half-life. CNS effects of dexmedetomidine, typically hypnosis via the locus coeruleus, and then analgesia via the same site as well as the spinal cord directly. And it can cause an increase in growth hormone and a decrease, it can occur in the cerebral blood flow with no change in the ICP or the CMRO2. Cardiovascular effects, you may see a decrease in heart rate, cardiac output, blood pressure, as well as circulating catecholamines. The effect is a dose-dependent effect. Bolus may result in an increase in blood pressure and a decrease in heart rate. Heart block and asystole may also occur secondary to unopposed vagal stimulation. Respiratory effects of dexmedetomidine are specifically a mild decrease in respiratory rate. There is a preserved CO2 response. The upper airway obstruction can still occur due to sedation, though, so that should be carefully monitored for. There is also synergism with other sedatives, so it can be used in a multimodal approach to sedation. Indications are really sedation in intubated patients. It can be used as a co-anesthetic in general anesthesia. It can also be used for sedation with upper GI procedures, awake intubation, even for upper esophageal procedures like EGDs. Side effects that you might see with these patients is specifically a dry mouth that patients might complain about afterwards.